All right. Well, hi, everyone. Thanks for coming to the presentation on trauma-focused cognitive behavioral therapy, also known as TFCBT. I'm Sherry Mabel Biskins. I'm a licensed master's level social worker over here at the Traumatic Stress and Treatment Center at Sanford. We're located in the professional building. And I'll tell you a little bit about me first. I've been a social worker for over 20 years. Just recently went back and got my master's and decided to pursue therapy, something I've always wanted to do. I really became interested in trauma when I fostered and adopted my three kids that were through the foster care system in Iowa. And I kind of got that interest just because they had had a traumatic past. My favorite thing about TFCBT is building relationships with my patients and graduating patients. And I know a lot of people call them clients here because we're part of the clinic. We call them patients, um, but it's so fun to watch these kids do all the hard work, accomplish their goal, and graduate from therapy. Um, just going to give us a little trigger warning just in case when we talk about trauma. Sometimes there can be triggers for people. So if you need to step out or take a break, feel free, but I'm not telling too many stories or anything, so it shouldn't be too bad. Just a warning. I'll start with kind of the prevalence of child trauma. There is, and this is a little bit of an older study, so it's about 10 years old, so it could be higher than this, but approximately 60% of our youth have experienced at least one trauma by the time they turn 18. And that percentage is higher in an inner city, up to 90% of kids who come into the ER, and overall, about 80% of kids in the inner city have experienced at least one trauma. I was going to show this video called Through Our Eyes, Children, Violence, and Trauma and How Trauma Impacts. But it's it's kind of graphic, I think, just in the stories. And so I chose not to share it, but you guys can surely go out and watch it on YouTube if you want. It's really good. Just had a lot of some of the stories that people experience. So trauma types can vary greatly. Domestic violence, sexual abuse, physical and emotional abuse, neglect, sexual assault. We can do like cases of where there's just like an accident or medical trauma, or even a loss of an important person in your life, are just a few of the different types of trauma that we can treat through TFCBT. As you guys probably all know, trauma has great consequences. Nearly everybody who's experienced a trauma has some acute distress at first, as would all of us if we experienced a trauma. PTSD is common, but it's not a super high amount of kids that develop PTSD. They might develop a different stress or trauma diagnosis, but PTSD, about 20% of kids who experience trauma end up with the diagnosis of PTSD. And in the inner city, about 49% of kids who experience trauma end up with that diagnosis. Trauma in childhood is linked to mental health issues and chronic disease in adulthood. You guys are probably familiar with the ACE study, but if you want more information on how trauma can impact you for the rest of your life, there's really good information in the ACE study that can tell you a little more about that. An intervention that is helpful for trauma and something that we do over here at the Traumatic Stress and Treatment Center is trauma-focused cognitive behavioral therapy. And just so you guys know, like you can't, or some people I think can do TFCBT without certification, but everybody in our office is a certified therapist for TFCBT, which means they attended some online modules first, then they attended a 2-day training. Then they have to complete the TFCBT protocol with at least 2 patients during a 6-month consultation period, where you share stories and about your patients and how people are doing and what they do in each component and everything like that. So it is a little bit of to become certified, it takes a little bit of time and work to do that. As I kind of mentioned earlier, trauma is a sensitive topic, and there are probably survivors or trauma survivors right here in this room today. And it's important to find a therapist that is a good fit for your child and your family. Someone says here, and I really like it, it's kind of like trying on clothes. Sometimes you have to try on more than one outfit to find the right fit. And it might be the same way with a therapist. You might go and just feel like your child might not feel like a good connection, or you might not feel a good connection. And that's okay. It's okay to look for a different therapist just because they aren't a good fit for you. Okay, well, let's talk a little bit about what TFCBT is. It was established by Cohen, Marinero, and Deblinger in 2006 as an intervention to help traumatized children, mainly with PTSD, but we can also work with kids who have other trauma diagnoses and they're non-offending caregivers. And now the therapy is used worldwide. It differs from other therapies in the fact that it's very structured and that it has a strong caregiver component. So we really like parents to be involved with the therapy. It's not you come and drop your kid off and come back in an hour. We want you to really be involved in part of the therapy with them. And it's structured. So typically down below it says like 8 to 16 sessions or longer, depending upon the extent of the trauma. We typically tell families 12 to 24 sessions. So we kind of say like 4 to 6 months is about the length of treatment. And typically we really like to meet weekly because then the kids are practicing those skills and learning each week. There are 3 phases to treatment. There's the stabilization phase, which is where they learn their PROC skills. And we'll go into a detail about what these things are a little bit further down the road here. Then they'll do the trauma narrative in their processing phase, and then they do the integration and consolidation phase. Parenting skills and gradual exposure take place in every phase of the treatment. So we're going to be kind of gradually exposing them to the trauma that they've experienced and working with the parents every step of the way. So TFCBT targets PTSD and other stress-related disorders, but it's also very helpful in decreasing depression and anxiety and behavioral symptoms. So that's the nice thing. You kind of can kill a couple birds with one stone in this situation. And it is effective for kids 3 to 18 years of age. It can be used, like we said earlier, in lots of different types of trauma. There's the single incident trauma, like maybe a child was in a car accident or witnessed something. It can be for chronic trauma, kids who maybe have been sexually abused for years or things like that. And then complex trauma. And the difference between chronic trauma and complex trauma is when the child is abused by someone that was supposed to be a caregiver or someone that they trusted. It can be done with or without parent participation, although the best results are when the parents are involved. It can be utilized in a variety of settings: an outpatient setting, a school setting, group home, foster home, and in-home. So we can use it in a lot of different settings. It's a structured treatment, and like I said before, it's mainly completed in 12 to 24 sessions. And research shows that 80% of kids who do TFCBT show a significant improvement in less than 16 weeks, which is a really, really high rate of success compared to other treatments. When the parents are involved, research also shows that there's improved parental distress, support, and depression compared to other supportive treatments. So it's effective to help the kids and to help the parents. The goals of TFCBT are to help children and the parents who have experienced these traumatic events, and helps also support the parent or the caregivers. We want to help them learn coping skills to deal with some of these emotions that they have and some of the behaviors that they have that are maybe related to that event. We help them face and resolve those problems in a safe and effective therapeutic way, and we want to help them kind of integrate those trauma experiences into their life so that they can move forward. We kind of tell them when we meet with them that we can't make the bad thing that happened go away, but we can but our goal is to help them so that they're not impacted by it every day. You know, hopefully it just comes up maybe once in a great while. There's a trigger and they kind of think about it, but it doesn't like affect them daily any longer. And it's designed to kind of reduce those symptoms of PTSD or other stress or trauma diagnoses, that depression, anxiety, those behavior problems. And then we really kind of work on the cognitive things such as fear, shame, embarrassment, guilt, and self-blame, helping put those where they belong, and take them out of the children's kind of life. So, and it also improves the caregiver support of the child. So we work on parenting skills and we really want to improve parent-child communication. Another thing that I think is really neat about TFCBT is there's a lot of different adaptations. So you can use it with a lot of different kids from a lot of different situations or cultures, situations, things like that. We have HCMC, which is called Healing Children Mending Circle, and everybody in our office has been trained in that as well. So it's an adaptation for Native American youth where we kind of bring culture into their TFCBT. And we actually also have a grant here where we called Project Heal, where we're trying to actually reach more Native American families and be able to provide more therapy, hoping that by having this training that we can be, they'll develop more trust with us. So that's something that is really cool, and we do that pretty often here. We also have an adaptation for racial socialization, so working with Black youth and families. There is a manual for IDD or developmental disabilities. There's another manual out there for kids who've been sexually exploited or sex trafficked. And then there's another one for specifically for the LGBTQ community. So we have a lot of different adaptations, which are really, really helpful. Like with the racial socialization, sometimes it's even helping them with some of the trauma that might have come just from being a different race. So they're really, really, really good adaptations out there to use. Some of the symptoms you might see in a child who has experienced trauma would be the effect of trauma symptoms like fear, sadness, anger, anxiety, and dysregulation. Some of the physiological symptoms might be irritability, difficulty with concentration, sleep issues, maybe difficulty falling asleep, difficulty staying asleep, or waking up really early, or not hardly having a hard time getting up at all, anger outbursts, impulsivity, or reckless behavior. We also see some cognitive symptoms like irrational or erroneous beliefs about themselves or the world or other people, reduced trust, negative self-image. Sometimes they might be accurate cognitions, sometimes they're inaccurate cognitions, but they're definitely usually unhelpful cognitions. So we help them change that thought later down the road. And then some of the behavioral things we might see is avoidance, maladaptive behaviors such as sexualized behaviors, violent behaviors, or bullying behaviors, angry outbursts or temper tantrums, substance use or abuse, self-injury, or traumatic bonding. So those are some of the things that we attack with our treatment. The core values of TFCBT are that it's components-based, it's respectful of cultural values, it's adaptable and flexible. When we talk about the components, sometimes we combine components to make that a little bit more flexible and helpful for families. It's family-focused, of course, in most therapy, but in this therapy, therapeutic relationship is really important. We want to have a good relationship with the child and with the parents, and that's going to give us the best results. And then self-efficacy is emphasized. So a lot of times when we're teaching this, we want kids to kind of almost see themselves as become their own therapist as they learn these skills so that they can use them down the road when something comes up. And some of the difficulties that we address, the things that we address are the cognitive problems, relationship problems, affect problems, family problems, traumatic behavior problems, or somatic problems. TFCBT has 8 components. Typically, we go through most of these. There's a few of them that sometimes we don't need in every situation. The first is psychoeducation and parenting skills, relaxation and effective modulation, cognitive processing, the trauma narrative, and then in vivo desensitization. That's one that sometimes we don't always utilize. Conjoint parent-child sessions, and then enhancing safety and social skills. So the first one we usually address with both the parent and the child is psychoeducation. So we want to kind of normalize that the feelings and behaviors that they're experiencing are kind of common of someone who's experienced a trauma. We provide information on how we react to stress, like be it our body, be it our brain. An example might be the brain flip by Dr. Siegel, like explaining to them how the brain flips. We want to instill hope in them right away that this treatment works for most kids and that a lot of them see a significant improvement pretty quickly. And then we just provide more information about different types of trauma, what might be your typical reactions. And then we always, right in the beginning, when we do an assessment, we typically diagnose the child and then we tell them, you know, what their diagnosis is, what those symptoms are, and kind of address that along the way. I think I put this in there later, but one of the things I really like about trauma, right? Because there's not always so many things to love about trauma, but one of the things I really like is when you give a kid a diagnosis that's either PTSD or stress or other related disorders. If they complete the treatment and they do well, like that diagnosis can no longer be a diagnosis that they have anymore. So a lot of times in mental health, we don't just get to get rid of our diagnoses, but these they can once they develop the skills and no longer have some of these symptoms. Parenting skills is really important. And it's not that sometimes these parents don't know how to parent. It's like when your child's experienced trauma, like you might not know how to handle that, right? So we involve the parents because they are really, really critical therapeutic agents of change. They're with those kids 24/7, or most of that time. We are only with them for an hour a week. So we want these parents to become the people that they can go to when they have problems. We want them to really help them, support them, and so that's why they're really, really important in here. We want them to be the person that the child turns to when they have trouble the next time, or when things go wrong. We want them to go home and talk to the parents. And we emphasize positive parenting skills such as praise and then being able to really enjoy time with your child. Some of the things that the creators of the TFCBT have said is that treating parents resulted in decreased behavioral and depressive symptoms in the child. The parent's emotional reaction to trauma was the strongest predictor of treatment outcome other than the treatment type. So parents are really, really important. And at the 12-month follow-up, parental support was significantly related to decreased symptoms in the child. Another thing, I did put this in here, but TFCBT, when they have done, it's a very evidence-based practice, and they have looked at 6 months, a year down the road, and kids continue to get better once they've done the treatment. So. One of the other components is relaxation. Sometimes we combine relaxation and effective modulation because they're very tied together. Like when you identify your emotions and your kind of your where you feel that, how strong you feel that emotion, but then we also use those relaxation skills to help them calm down those emotions. So we use that relaxation to kind of help with the stress of the PTSD. Kids who experience PTSD might have stomach aches or headaches or that hypervigilance, like they're always looking around waiting for something bad to happen or, what's going to happen next. Intrusive memories where those memories kind of come at inopportune times, like when they're trying to go to sleep at night or when they're feeling sick. And so, we help, those relaxation skills can help with that. Heart racing, tense muscles, things like that. And typically we try to develop kind of an individual relaxation strategies for each child. So we have many, many different ones to choose from, and we help kids pick what works best for them. And sometimes we'll make like a toolbox, depending on the age of the child, whatever works best for them. And if the relaxation component isn't fun, we're not doing it right? So we want that to be fun, something that they enjoy doing, and something that really works for them. Then we have affective modulation, which is like I said, we kind of interact or relate with relaxation skills. So this is when they can identify their feelings, where they feel those feelings in their body, what are some signs that they're starting to feel angry, like are their face getting red or their fists kind of like balling up, things like that. So we help them identify those feelings. We help them rate how intense is that feeling when they maybe think about this trauma or different situations. And then we help them use those coping skills, practice using those coping skills when they have those feelings. Traumatized kids sometimes have a restricted range of affective expression. So that's something we can spend a lot of time with sometimes. I have a little guy that we really never even had to do the trauma narrative. We just mainly worked on these practice skills. So the psychoeducation, the relaxation, the affective modulation, and then the cognitive coping. And once he did that, he was actually ready to graduate. He didn't need to go on to any further. So they're really important. And then cognitive coping, that's the last part of the practice skills. And that's when we help parents and children understand the cognitive triangle. So the connections between our thoughts, our feelings, and our behaviors, and how they relate to everyday events. And then we want to help them learn that they can develop alternative thoughts that might be more accurate or helpful. So, and that will be some kind of a foundation for later when we do cognitive processing after they tell their trauma narrative. And then in the caregiver sessions, we also help the caregivers kind of look at their thoughts, feelings, and behaviors because they probably have them related to the trauma as well. The trauma narrative is the opportunity for the child to tell their story. And some people really, that's the scary part, right? So we don't always tell kids right away when they come that we kind of tell them they're going to get to tell their story, but we don't like go into details because that causes a lot of anxiety. Sometimes they don't want to talk about what happened. But the reason that we do a trauma narrative is because we want those kids to kind of gain that mastery over their trauma reminders. And we want them to kind of not avoid things any longer because avoidance is what keeps that PTSD going. And we do have people who come and don't finish because they're not ready. And that's fine. We just tell them, we'll just put, you can be added back onto the wait list, or you can just call when you're ready, because sometimes people can start and realize, oh, maybe I'm not quite ready yet. But, the sooner we can work on it, the better, because it helps you go forward. But we also don't want to push people to do something they're not ready for. We do a correction of distorted cognitions. An example might be the assault happened because I wore a short skirt, right? Our society sometimes tells us that we cause things when that's not really the case. We also model adaptive coping. So we help them learn how to use coping skills when they're telling their story. We identify and prepare for their trauma loss reminders. So after therapy is done, things might come up that remind them, and how are they going to handle those things? And then we help them kind of put those traumatic experiences into their life. So even though, like I said, we can't prevent or we can't make this go away, maybe we learned something from it, or we've grown because of it. The child will tell their story of the traumatic event however they want to. So sometimes we might write a book, sometimes they might draw pictures that tell their story. Sometimes they write a poem or a song. So they get to be really creative when they're telling their story, and we try to make it based off their interests. So it's something that's comfortable for them to do and something they enjoy doing. Then we help them process the trauma. So we're going to identify with the child and the parent different cognitive distortions they might have. Like, an example, a child might think like, I must have did something to deserve this, where, later we want them to realize that a child never does anything to deserve being abused. We use cognitive processing techniques to help replace those accurate and help replace those inaccurate distortions with more accurate or helpful thoughts about the trauma. And we encourage parents to reinforce their more accurate, helpful cognition. So when they see their child saying something that's more appropriate, to praise them and to really help support them. In vivo mastery of trauma reminders. This is something that I haven't used very often. This is more of when there's something that the child really has a fear because of the trauma. So it might be, we're going to identify or assess that feared situation or trigger. So maybe an abuse occurred in the bathtub. We're going to help that kid be able to go get in the bathtub. And by doing kind of like a plan to get him there and in and out of the tub and be able to do that without such fear. So we engage both the child and the caregiver in that plan, because a lot of times as a therapist, we can't do that with them. It's outside of here. So we'll help them come up with like a plan. How are we going to do this? We were just talking about this morning, like a child that maybe is scared to sleep in their room in the dark because that's when the abuse happened. So how are we going to get him to go back to his room and sleep in the dark? And so it might be a process of like, mom's going to check in on him, or we're going to have him sleep in his room 3 nights a week, and mom's going to check in on him every 20 minutes for the first week, and then he's going to get a prize if he can do that. It's a kind of a plan to help him move back to that room without the fear that he originally had, and we do that through exposure. Another example could be like a sexual assault that happened in a parking ramp. How do we get someone back in that parking ramp after something like that happened? So that's something that a lot of times by the time the kids get through the trauma narrative, they don't need to do this. They've already kind of already went through this, but sometimes we have to do that as well. Then we have conjoint parent sessions, and that's where the kids, typically when we do the trauma therapy, like we'll meet with mom or dad like for 10 or 15 minutes, and then we'll meet with the child the other portion. But when we get towards the end and when they start to share their story, then we have sessions together with the parents and the child. And that's where they're going to share their experience. We're going to kind of talk about cognitive distortions that maybe the child or the parent have. We're going to kind of really encourage the parent and child to communicate. We do get some teens that don't always want their parents to be part of the trauma narrative. Like they don't really want them to know everything that happened. But we have also done that with, we want that to be the child's choice. So sometimes we might not share everything. Like they'll share what they're comfortable sharing, which I think is still, a positive. We want to help them prepare for future traumatic reminders. We want to help model how we can support the child. And then a lot of times when the child does their narrative, then we have parents write praise letters for the child. And we have kind of like, that could be scary for a parent, but we'll have like a template that they can kind of use, and something that those kids really mean a lot to them when their parents tell them how proud they are of them and how much work they did. And it's really, really helpful for the kids and really great for them. And I cry every time I hear a praise letter. The last thing we want to do is enhance safety. Sometimes this is done at the very beginning before we even start TFCBT2. If there's like if a child's been sexually abused, we might teach them body safety skills right away, because we want them to, not be victimized again. So sometimes we do it at the very beginning and at the end. Sometimes we just do it at the end. It may include a safety plan. It may include these body safety skills. It may include practicing these skills outside of therapy. Sometimes with teens, or I guess it doesn't have to be just teens, but we'll do education on like sexual health and healthy relationships, assertiveness training, and then children who have been exposed to domestic violence, physical assault, or community violence. We might also do some education about bullying or conflict resolution or things like that as well. And then the best part is when we graduate the kiddos. So when we get close to graduation, when they've told their narrative and they're kind of work through the cognitive processing, then we start to kind of assess, are they ready to be discharged? Some kids are super excited to be done with therapy and never have to come back. And then some are a little bit like hesitant, like I've been coming and now I don't know if I want to do this by myself. So we do kind of fade out, or we have booster sessions, or I've had a few kids who graduated who come back when other situations come up, just because we don't, some of these kids can, it's hard to build that rapport, and we want them to be able to come back and not have to tell their whole story again. So, so sometimes when they graduate, they will continue to come back a little bit. We'll discuss and plan for like natural setbacks, things that might happen along the way that might bring back some of those triggers or things like that. We'll encourage kids that they can do this without us, that they don't need us. I actually think to me, I don't know, I see it as, I'm going to say it, not really a compliment, but like, I'm really excited when a kid doesn't feel like they have to come back to therapy, like they feel like they can manage it on their own. And we do know that like, just because they graduate from TFCBT doesn't mean they might never need therapy again, but they hopefully don't need it for the trauma anyway. We want those parents to continue to be a therapeutic resource for them, and because they've learned things along the way too, so they can help them to like, maybe like, hey, let's look at that. What thought do you have because of that, and how are you feeling, and what's your behavior, and how could we look at that differently? We review skills and progress achieved, and then we celebrate. So we have the office set up like a graduation ceremony with congratulations, and they get their little certificate that say they've achieved this. And we usually have either a snack or a meal depending upon when they typically come. So if they come around lunchtime, we'll do like pizza. If they come at 3 or 4, we'll do like cupcakes and just celebrate that. So a lot of times I base that very much on what the kid wants to, like, what would you want? And when they finish their narrative, or at this point too, they typically get a prize from our prize closet for coming and doing all the work and meeting their goal. And I guess I didn't tell you guys too, so TFCBT is what we do for kids 3 through 18. Some of us over here work with adults as well. And we do a different trauma therapy for that. We do cognitive processing therapy, which is also a structured therapy. It's typically can be done in 12 sessions. And I really enjoy doing that too. I think I've had one person graduate from it so far, like, and boom, just all the way through. And I think we went one extra session. So he had 13 sessions and he graduated. So it's really fun to see people move through that therapy. And so maybe they experienced that trauma when they were younger, or maybe it was something they experienced as adults. But it's really fun to see them accomplish that goal and be able to move on. So I think that's about all I have. Do you guys have any questions or anything?